Thank you. Our third speaker today is going to take us a little bit away from the classic microbiology lab, but to a disease that is of importance to all of us everywhere, and that is the disease of sepsis. It is important in microbiology, but Dr. Holden is going to discuss hematology assays and using hematology assays to assess the risk of sepsis. Dr. Holden received her MD from Emory University and is currently the Chief Medical Officer at Beckman Coulter. Dr. Holden?
Thanks very much for that introduction, Dr. Zimmer, and it's a pleasure to be here at ECCMID. This is the first time I've attended this meeting. I am a hematopathologist by training, but of course I'm a general laboratorian as well, and it's a pleasure to be able to actually see microbiology at work. My only disclosure is that I am a full-time employee of Beckman Coulter, which is a subsidiary of Danaher. So what we're going to talk about today is some background about sepsis. We'll talk about what is sepsis, how do we know what it is, and how do we diagnose sepsis, how and when, very specifically. How quickly we need to treat sepsis. And this, of course, really is where the intersection with microbiology comes in. Because the sooner we can administer effective antibiotics, the sooner we can get the sepsis process under control. I'm going to speak specifically about the hematologic findings in sepsis and the insights they can actually give us into early identification of sepsis, and then we'll make draw some conclusions. So generally speaking, sepsis is an enormous burden on our population worldwide, as well as on our healthcare systems. In excess of 26 million people are affected by sepsis. In the US, it's the third leading cause of death. We know that the incidence of sepsis is increasing overall. There are a number of drivers for that, including the fact that we live longer, as well as increasing incidence of diabetes are both drivers there. Approximately 2/3 of patients with sepsis will actually present to the emergency department. So although you will find patients who are septic in other parts of the hospital, that's typically where we are most interested in identifying them. Importantly, we also know that the sooner you administer antibiotics, especially to patients who are already in severe shock or septic shock, the lower the mortality as well as the morbidity. So we are certainly interested in identifying sepsis quickly and treating it appropriately. So I will point out that although sepsis is triggered by a pathogen, typically bacterial or fungal, it is in and of itself not the infection. It's actually your body's immune response to that infection, and there are actually two components to it. There's actually a hyperstimulation of your immune system, which ultimately, if it goes unchecked, will result in end organ damage and can actually lead to death in a not small percentage of the population. In some geographies, this may be as low as 20%. In other geos, in excess of 50%, depending on how quickly these patients are identified and treated. Unfortunately, at the same time that your immune system is being hyperstimulated, it's also being suppressed because that's your body's response to anything that's in overdrive. And so paradoxically, despite the fact that you're infected, you are actually experiencing immune suppression, which makes it just that much harder to clear the infection. Now, for patients who survive the immediate septic crisis, these patients typically actually have chronic immune dysregulation, and this typically has a component of immune suppression long term. And we know that patients that survive sepsis often have higher long-term mortality as well as morbidity for other reasons. This is a schematic that actually shows what I just showed you in a little bit more detail, showing you some of the pathophysiology. And I'll draw your attention to, on top we have the pro-inflammatory response, on the bottom we have the anti-inflammatory response. And the fact that early in the pro-inflammatory response, white blood cells play a very important role in this process. And we'll talk about this later as we get to the insights you can gain from these cells. And then now we're looking at the cellular and tissue level in terms of the mechanisms of action. The sequelae of sepsis include organ failure and death, and these typically are multifactorial. So for instance, these patients will have vascular collapse. And there's several different things that cause that, but one of those underlying etiologies actually has to do with the microclotting. So one of the findings you'll see in patients with sepsis actually is thrombocytopenia. And this is actually a consumptive thrombocytopenia. It isn't that they don't have enough platelets, they're using them to actually form blood clots. And again, you'll see in the upper left hand of the figure, monocytes and as well as neutrophils play an important role in the early steps of sepsis. And then finally, we have a schematic that actually shows the pathway going from initial infection and your body's responding with as a septic response, the importance of the innate immune system in terms of the neutrophils and monocytes that are present. Monocytes actually elaborate a number of cytokines. They help actually drive the process, and they also respond to the cytokines. These effects are felt systemically. The cytokine storm is one of the terms people use to describe it, and it's seen across all organ systems. I mentioned the consumptive coagulopathy that's characteristic of sepsis. And when you get to the point of severe sepsis and shock, you'll actually see manifestations across many different organ systems, including your bone marrow. So you'll actually eventually see suppression of myelopoiesis and granulopoiesis, as well as there's some issues. So there's some impacts on red blood cell membrane deformability that actually can contribute to your anemia as well. All right, so I'm going to switch gears a little bit and talk about how we diagnose sepsis. As I said, sepsis is most frequently identified, or patients enter the healthcare system through the emergency department. And this is a very simplified schematic that starts with initial triage up in the upper left there. And that's when the patients, there'll be some kind of acuity assessment. Typically, this involves assessment of your vital signs and just general how much pain the patient is experiencing. And also typical of that early part of the encounter in the ED is that laboratory testing is drawn. And this is typically peripheral blood, perhaps a urine. And the testing that's seen most commonly is a CBC with white blood cell differential count, as well as some basic clinical chemistry assays. And this is done depending on the geography you're in, either on every patient that walks in the emergency department or a good subset of them, say those that haven't had broken legs or something like that. And based on that information, then the physician will see the patient and perhaps a nurse and needs to make an assessment. Is it possible that this patient is septic? And the criteria that we use to decide whether or not this patient is septic include things like vital signs. So there's actually two systems. There's something called QSOFA, Quick Systemic Organ Failure Assessment, which you can do in the ED, as well as looking for what is called SIRS, which is Systemic Immune what's it called? SIRS. Anyway, is basically how we identify patients with sepsis. And these are basic things like tachycardia, tachypnea, fever. The SIRS criteria do include one lab test, and that's the white blood cell count. It's either higher than 12 or lower than 4. Then, of course, we're certainly looking for signs of infection. Known or suspected infection will certainly drive the decision towards sepsis in a patient like this. If indeed the clinician decides that this patient is in fact at risk for sepsis, that's when additional testing is run. Of course, very typically you'll do blood cultures. That's quite common, and if you suspect any other side of an infection, you'll probably do that as well. But there's some other biomarkers that people use at this stage of the ED encounter to either rule in or potentially rule out the possibility of sepsis. And this is actually a systematic review and meta-analysis that was published in 2016 by Liu et al. And this was actually looking at some of the assays that are drawn, not at that original triage of the patient, but after the clinician has become suspicious of sepsis. And if you look at the different assays, you can see procalcitonin is at the top, and that's one that's actually used in some geographies now routinely as standard of care. Some of the others are performed, but not necessarily as standard of care. In the US, actually, not even procalcitonin is run routinely yet. It typically relies on lactate. And then there are a number of other assays. All of these assays are not drawn initially when patients enter the ED. They're actually drawn only after a clinician becomes suspicious that a patient has sepsis. And not all patients are immediately evident. Some of them will be, but some of them either because they have confounding comorbidities to which you can attribute the symptoms of sepsis, or who are young and otherwise well compensated, who may not manifest the signs and symptoms of sepsis as early in the course as you'd like. Both of those populations are at risk for being missed. I'll draw your attention to one of the assays here, which is actually CD64. This is the one at the very bottom, and if you look at the area under the curve for this particular assay, it looks really excellent. It's 0.96. But the authors of this paper point out there are only 4 papers. At that point, it had only been 4 papers that they included in their analysis. And additionally, that there were not a whole lot of patients involved. And it's quite typical that, as you know, the data typically looks better when you first look at an assay, and as you get more information, it's not quite as strong. But there's another issue about this particular assay. Even if it were this good, it's an assay that's performed on a flow cytometer. And the way the assay works is you actually look at CD64 expression on one of the types of one of the cells in the innate immune system, that's neutrophils. So neutrophils do not normally express CD64. They gain CD64 in the setting of bacterial infection and sepsis. And so it sounds like a pretty good assay, but it's only a good assay if it's available 24/7 in your hospital and can serve your ED patients. This assay similarly also suffers from the need for expert technologists to do it. There's an interpretive component, and it can take, depending on where you do it, at a minimum, it would take an hour to run this assay, more likely 2 or 3 hours to get it, and of course you can't get it in the middle of the night. So just some data in terms of this timeliness of therapy and how important it is for patients who do present in severe sepsis or septic shock. Every hour of delay in antibiotic administration it results in about approximately 8% increased mortality. So just to summarize what we know about sepsis, it's deadly and costly. Confounding symptoms and comorbidities may delay recognition and treatment. And we do know that early identification and treatment improve patient outcomes and reduce mortality. But then we are asked the question, well, how fast is fast enough? And this was actually a case vignette that was published in New England Journal of Medicine last week, so a very timely topic. And the case is someone is being asked whether or not they should switch from what is called a 3-hour sepsis bundle, in which your goal is to actually get patients treated in terms of giving them volume, essentially addressing potential hypotension, as well as get them started on antibiotics and all their labs drawn within a 3-hour time space versus a 1-hour time space. And the 2 authors here, of course, are being deliberately controversial here. Steve Simpson from the Sepsis Alliance specifically points out that if you if you delay another 2 hours, that you're missing the opportunity to intervene earlier with septic patients. On the other side, there's this concern that if you are acting too quickly, that there's risk for over-treating non-septic patients. And you can actually break those down. There are different concerns. One is the cost of treating these patients, albeit single-use antibiotic overuse, fluid overload in patients who might have congestive heart failure. You can't tolerate the fluid load because that's part of the sepsis bundle. And probably most importantly, diversion of ED resources from other acutely ill patients. There's a great deal of concern about this. So the jury is out. I think aspirationally, we all know that we want to treat patients with sepsis more quickly, but it might be helpful to have more information. So we're going to go back to that ED triage, and we're going to ask this. So this is all the same information you saw before, but we're now going to look earlier in that care pathway and ask the question that's encircled here in red: can we obtain better information early in the care pathway? So I talked earlier, when I was talking about this pathophysiology of sepsis, about the innate immune system. Both neutrophils and monocytes play a very important role in sepsis. And in point of fact, when we do a CBC with white blood cell differential, we're actually measuring those cells. We're not just counting them, but we're characterizing them in great detail. That information is typically not reported on a hematology analyzer, but it is available certainly on our analyzers. And so we decided to look at this, and we actually embarked upon a trial that is now considered the feasibility trial for we now have a pivotal clinical trial for which that we've submitted to the FDA. And so to answer the question, can we obtain better information early in the care pathway, we did this study. We've known for a long time that in response to stimuli, that the cells of our innate immune system, when they become activated, change their volume. We can see this when we look under the microscope on a peripheral smear. It's quite evident. They actually change some other features as well. And so we wanted to see whether or not we could actually detect these changes in our hematology analyzer. And just to give you an idea of how this is done, when you actually are doing a CBC with differential count, each of those cells passes through an aperture across which you passed an electric field, and you were actually looking for the impedance that's the result of the particle. You can use this to count the particle or the cell, but you can actually use the size of the impedance to give you a sense of how big the particle is. And depending on how well you do this, you may be able to look at very small differences. So if we look at the left, this is actually the printout you get from a CBC with white blood, the white blood cell differential. And this is a patient who is not septic. The events in blue are lymphocytes, and on the parameters we're looking at on the x-axis here are cell complexity, and on the y-axis is cell volume. So you can see that the smallest, least complex cells in your peripheral blood normally are lymphocytes. The very complex but moderate in size orange eosinophils, so orange for the Netherlands, we'll say. Those are depicted here. Neutrophils are in purple. And the largest cells that are circulating in your peripheral blood quiescently are your monocytes. And over on the left, where what we're depicting there is cell volume, you can actually see that we have a nice Gaussian distribution. We're essentially creating a histogram of those volume measurements. And we can actually derive from this a mean monocyte volume. We can also generate statistics around those events, all those green events, and actually generate a standard deviation. And this is actually described as a monocyte distribution width. So for those of you who do hematology, this is analogous to the red cell distribution width that we do when we look for different types of anemia. On the right, I have a patient who is septic. So all the cell populations are there, but they're there in different relative numbers. And if you look at the scatter pattern of the green events in the plot on your right versus the plot on your left, you'll actually see that there's a much larger distribution in the cell volume. So no longer does it look Gaussian. It looks like it's kind of shifted now a bit, where it's kind of piled up on the lower end of the volume, and then there's this tail on the right. And if you actually look at the scatter pattern, you can actually see that many of the events are piled up at the upper edge of the plot. We see a similar finding for neutrophils, where again you see that distribution is different between the sample on the left and the sample on the right. So we actually looked at all four of these parameters. So we actually looked at the mean neutrophil volume. Then we looked at the neutrophil distribution width. We looked at the mean monocyte volume and the monocyte distribution width. And these are all plotted here in terms of how well, what the measurements you'd see in patients who, for each of these plots, the bar on the right is for somebody who is septic. The bar on the left is for someone who's not ill, for somebody who's well. And then the two in the middle are patients who either have SIRS, so they have findings that suggest they may be septic, but don't have an infection, so they're not. And then patients who are infected but don't have SIRS, and so they also are not septic. And if you look at these closer, you'll realize that it's the one in the bottom right, the monocyte distribution width, that best distinguishes patients who are septic from those who are not. Now, if you don't know that much about monocytes, you say, well, why monocytes? Well, it turns out that monocytes, they are, of course, part of the innate immune system, and they're actually drivers. Unlike neutrophils, they are, which respond to cytokines, monocytes actually elaborate a lot of cytokines, so they actually are recruited quite early in the process. They do display a lot of heterogeneity. I actually have two photomicrographs here that show on the top a quiescent monocyte, and then on the bottom an activated monocyte. You can see that the cell is larger, it's quite vacuolated, the the chromatin's looser, and these are things we see when we look at them under the microscope. They do display heterogeneity in their immunophenotype and their function. We talked about CD64 on neutrophils. You can actually do similar measurements for different markers on monocytes, and you could actually get insight if you were to do flow cytometry, but again, that's not going to happen currently at 2 in the morning. But it turns out we don't have to do those measurements because that functional heterogeneity is reflected in the morphologic heterogeneity. These patients literally, these monocytes literally change their physical properties in the course of adopting a new function and immunophenotype, and we can measure it. And so when we did this in the feasibility trial, we actually looked at it together with white blood cell count, just because that's already being measured, right? We can get the same information at the same time. This happens very early in the ED encounter, very possibly before the physician has even seen the patient. I'm sure you've seen ROC curves before, but just to point out, the farther into the upper left-hand corner you can drive your curve, the better. The area under the curve for a white blood cell count alone, which is actually not bad for distinguishing septic from non-septic patients in all comers, was 0.81, and then MDW all by itself was 0.79. But it's where we actually combine them together, where we actually look at an abnormal white blood cell count and an abnormal MDW, an elevated MDW in the same patient. And in the feasibility trial, this drove the area under the curve out to 0.89. So quite impressive, and we were very happy with that. On the right-hand side, we actually look at not all comers. We actually confine our search to people that have SIRS, and then distinguish patients who are septic from those with SIRS. And unlike white blood cell count, which does not perform well in this setting, MDW actually does. And I'll just show you a couple of cases. These are both patients from our pivotal trial. This is a 40-year-old female. Her CBC was drawn 1.5 hours, or with the results were ready 1.5 hours after she'd entered the ED. She does have a fairly complicated medical history, including Crohn's, associated inflammatory bowel disease, as well as anemia, which is not uncommon with that. It's just a normal white blood cell count, and her platelet count is normal. And if you actually just look at those colored colored blobs, the blue and the green and the pink and so forth, you can already tell me without looking at the numbers that this patient probably is not septic. This patient's MDW is 17, it's a little under 18. The cutoff is 20. And you'll notice that this result shows up with the remainder of your CBC and white blood cell differential. So in terms of the ED and that physician making clinical decisions, he or she does not have to know, does not have to suspect that the patient is septic to get these results. It shows up automatically with the results of your white blood cell differential. So this is this 40-year-old lady. She's not septic. She was discharged home. She's fine. This patient is an 18-year-old female who actually presented with pneumonia. Now, her CBC was drawn at the same time, but she did not have the findings of someone who was septic. She was on antibiotics, apparently. I don't know how an 18-year-old got pneumonia, but she has it. And it turns out that her final adjudication as her having actually met the criteria for a diagnosis of sepsis did not occur until 7 hours after her CBC results her CBC had been drawn. But I call your attention again to the plot where we look at the green cells and the blue cells and so forth. You can see immediately that her monocyte distribution width is going to be much higher than we would expect relative to the other patient. And in fact, her MDW was 28, well over the threshold. This was well in advance of her actually showing symptoms of sepsis. So that question that we answered in the red box before about whether or not we could actually get information early from the testing that we were already doing, the answer is yes, white blood cell volume measurements are informative. And in conclusion, sepsis remains difficult to recognize in some patients, actually many patients in many instances. Failure to treat septic patients early increases mortality and morbidity. Overtreatment of septic patients is a concern, so we may see that having this information earlier helps us to triage patients more effectively. And finally, that having monocyte volume, the monocyte distribution width available early in the emergency department care. We can get that information very quickly without placing additional burden on the staff in the emergency department or in the laboratory, since the results are available with the CBC and white blood cell differential. So thank you very much. I'll stop my talk there.
Thank you. Thank you for an interesting talk and a different perspective on looking at patients in different laboratory tests. Does anyone have any questions? Please come on up and or walk back wherever the nearest microphone is.
There you are.
Very nice presentation. My question is, probably is to how early is how early is the sign of the monocytes comparing with the white cells count that we use traditionally? And the second question, can we use that to monitorize the outcome of patients?
Yeah. So these are both great questions. I get these questions a lot. So the first question is, it's difficult to say how early this manifests because we're not going to actually give anybody sepsis. You know, how do you do that trial, right? We do know that it seems to happen early. There are a number of in vitro studies that suggest that it happens we do know that the monocytes are engaged very early. Part of the monocyte distribution width is related to the activation of your circulating monocytes, but where you saw that pile up at the bottom of the distribution as well, those were actually young monocytes that were being recruited from the bone marrow in response to the immune response. So we don't know for sure how quickly it happens. We do know that it happens early. And we don't act, and so, well, yeah, we know that it happens early. Now, your second question was, can we use it to monitor? So we don't know this yet because we did not test these patients serially. I will not be surprised to see that it's informative, but I don't have data to tell you that it is.
Thank you. We've got time for one other question, and then we'll probably put the rest of this in the panel discussion, if you don't mind. Thank you. Go ahead.
Congratulations for your presentation. And I have a doubt. What could happen with patients that have, some example, leukemia, that have a very high white blood cell count, or the patient that has chemotherapy or conventional neutropenia?
Yeah. So when we did the study, we powered the study, of course, to look for patients that were septic. In fact, the prevalence in our study, because of the way we designed it with the help of the FDA, was actually 18% of the patients overall were actually septic. And we didn't power it to look at patients specifically that were neutropenic or patients that had hematologic malignancies. That said, we do know that at least based on the relatively small number, not really statistically significant, probably, but on a number of patients who were neutropenic in the study, that our area under the curve actually looks very similar in those patients. So we think that neutropenia is still going to, we don't think that's going to be a problem. For patients who have hematologic malignancies, specifically patients who have monoblasts, there is actually a flag on the results saying if we also throw a flag for what we think are monoblasts, then it says, by the way, if you have a monocytic leukemia, you're not going to be able to use it if you have circulating blasts. Now, of course, you might throw that flag on the instrument when in fact all you have is a whomping case of sepsis, and that will trigger someone to actually look at the patient history and look at the peripheral smear. But both great questions.
Thank you.
Thanks.
Thank you so much. I think it really shows that it's one laboratory as well, looking at a lot of different results. So thank you.